the imagination of my super self. This is how we form frameworks for behavior. Smoking as a social norm is shaped in the case of men, for instance, in such environment. Therefore, it serves as a precondition for forming a dependency, and such a person would continue smoking regardless of the information about the harm of smoking. Undoubtedly, we need to understand the psychological aspects. Skinner's theory of operant conditioning is important here, and Skinner worked on the theory, developed a theory of how our behavior is formed. So he developed that a theory of Darwin-like selection, but in the field of behavior. So we behave in a certain way, it leads or does not lead to certain results. And so we have positive results. They serve as positive reinforcement, and they force us to repeat the behavior that has led to a positive result. So it is positive reinforcement. In here, it would be a possibility to discuss important issues in the smoke room, for instance. This may work as a positive reinforcement. In the post in the Belarusian army, but also in the Soviet army, the positive reinforcement was if you are a smoker, you have a break to smoke. If you're not a smoker, you don't have a break, you keep working. So that was a powerful positive reinforcement to start smoking so as to have a break. And not many people, well, if we look at a large population of people, not many people like working hard all the time. And having a smoke was a legal way to take a break. Because as a non-smoker, if you're a non-smoker and you want to take a break, you cannot possibly just leave the office to take a fresh air. It will not be positively accepted by your colleagues. But if you're a smoker, then it is there is more permissive environment for the smokers just to go out and take a smoke, have a smoke. So socially speaking, people understand that as a smoker, you are the smoker is dependent, therefore needs to take a break and go and have a smoke. And also sometimes you just go out with your boss to have a smoke, and it also works as a positive reinforcement. So positive reinforcement allows you to avoid something unpleasant. Apart from that, there may be negative reinforcement, that is smoking in a smoke room is a break from unpleasant work, and positive punishment, that is uncomfortable questions when a person refuses to smoke. For instance, as an adolescent, if you refuse to smoke with the peers, then there may be some ostracism. It is quite a negative, strong negative emotion. So the mere threat of such punishment increases the probability of smoking. And negative punishment in the case when an individual stops feeling part of the group. Nicotine is the primary addictive component of tobacco smoking, and nicotine activity is very well studied. Nicotine acetylene receptors are located in dopamine neurons and GABA neurons of the reward system, but from the point of view of dependency, these receptors are actually on dopamine neurons of the reward system. Therefore, once those receptors are activated, we have the enforced dopamine transmission, which activates the reward system, and this is how a person starts repeating a certain behavior. That is quite an acute effect. So you smoke and you immediately have a positive effect. And apart from dopamine, there are other neuromediators. For instance, such receptors on the GABA pathways. Glutamate is one of the activating neuromediators, and therefore the increased activity of glutamate presynaptic terminals increases the activity, and that is why nicotine acts as a psychostimulant. as a substance. This also reduced the activity of the GABA receptors, which is there is this explosion of activation because many pathways are activated at the same time when we're speaking about acute effects of nicotine. But there are also prolonged effects of nicotine in the shape of desensitization to the effects of nicotine. That means with repeat smoking, one has to smoke more to gain the same effect. This means that more nicotine has to be consumed. This is especially important in the faster forms of access to nicotine, because if nicotine is delivered by patches or in any other way that does not include rapid increase of concentration, then this acute effect works much slower. But the prolonged effect is that we have desensitization to the effects of nicotine, and also we see the increase in the number of N-acetylcholine receptors, which means that in the case of abstinence, the organism is more sensitive towards to nicotine, and there is this a sense of the first cigarette in the morning. So with time passing, a smoke has a lower level of satisfaction with the cigarette, but we know that the most pleasant cigarette is the first cigarette in the morning, because the nicotine level is reduced in the morning, but there is a greater craving for nicotine in the morning, and this is a very strong effect, the reinforcing effect. We also see the change in the synthesis of some proteins which lead to the activation of the BDNF factor in the brain. So the nicotine leads to the synthesis of some proteins like delta force B. Delta force B, which is a protein which is in normal is almost not present in the neurons, but nicotine starts the synthesis of delta force B that leads. But the delta force B has the prolonged half time, and therefore the synthesis takes a longer period of time, and that leads to the activation of the BDNF synthesis. And BDNF is important from the point of view of fixing a certain form of behavior. And once the behavior is repeated, in this case smoking, this effect is reinforced. Also, we see increased activity of the system regulating sensitivity to glutamatergic signals. We also deal with negative reinforcement. That is, the increased level of nicotine becomes a new norm for the organism. Therefore, if nicotine levels decrease, then we have a sensation of anxiety, a reduced mood, and therefore nicotine is needed so as to reduce the level of irritation or anxiety. During abstinence, nicotine abstinence, we see the CRF, the corticotropin releasing factor initiates the synthesis and release of cortisol. And once nicotine is delivered to the organism, again, the level of cortisol goes down and a person feels relief. However, what is important to bear in mind in this case, we need to be mindful of not only nicotine. There are other substances that in their mechanism of action are reminiscent of the monoamine oxidase inhibitors. Those are antidepressants. These are the substances that reduce the speed of nicotine metabolism, and this is how we increase the amount of dopamine that is released into the synaptic crevice. Acetaldehyde Well, we all know that acetaldehyde is a product of metabolism of alcohol, but acetaldehyde is also present in the cigarettes. Acetaldehyde, which is converted into salcinol, which is it is converted to salcinol in synapses, and it is an agonist of M-opioid receptors. So it affects the opioid system. Apart from that, we have some other alkaloids within the tobacco that are not really meaningful in their own right, but because some of the receptors are closed, they start reinforcing the action of nicotine. So, for instance, the nitrates or ammonia compounds are added to cigarettes. They increase the pH. Therefore, nicotine becomes more bioavailable, and therefore it is easier for nicotine to go through the blood-brain barrier, and thus it becomes more effective. Now, because of that, I have had a look at different data. That is the share of addicted people among those who tried this substance. Let's have a look. Those are the people who at least once in their lifetime tried MDMA or ecstasy. 6% of them will become dependent. I don't say it's global data, it's the US data. And because of the social factors, there may be some differences, but it's 6% of those who have tried MDMA become dependent. Of those who tried amphetamine at least once in their lifetime, 8 to 13% of them become addicted. Cannabis has 9%, cocaine 21%, alcohol 23%. Even the heroin, if we look at the share of addicted people among those who have tried it once, it's 30% for heroin. But look at nicotine. It's an absolute leader in this conversion of people experimenting with this substance. So speaking with the marketing language, there is the cigarette purchase funnel. It's super effective. If we open up a possibility for a person to have a smoke at least once, then 68% of those who try for the first time will become clients. So this purchase funnel is very effective, very attractive. And that is why in many countries, the level of smokers is not going down. That is because of this conversion rate. We see that the conversion rate of people experimenting with this substance is super high in the case of nicotine, and they become everyday smokers. Now, what are approaches to smoking cessation? I will give you just a brief list of possibilities. We will have a look at some drugs. Bupropion. In Central Asian countries, bupropion is not available. I think it is available in Moldova. It definitely is available in Poland and Ukraine. In Lithuania, it is available in Latvia, but as for Central Asia, I know it is not available there. Well, it is a recipe drug, but it's banned in Russia. In Russia, it's treated as a drug. It is an inhibitor of dopamine and noradrenaline reuptake transporters, and it reduces the severity of withdrawal symptoms. Now, the next products are citizens and varenicline. They were available in many countries as OTC, as Tabex. It's quite popular. It is an effective drug. It acts as partial agonist of nicotinic receptors. So it binds to the same receptors that are used by nicotine, but it does not activate these receptors as strongly as nicotine, but it stops nicotine binding with the same receptors. So it's a competitive, so it's agonist because it activates receptors, but it's not as strong an activator as nicotine. And it wins in the competition with nicotine when fighting for binding with these receptors, and then the nicotine itself We know, and many research shows, that if a person receives nicotine in whatever form, those could be patches or chewing tobacco or sprays, then nicotine becomes an effective way of reducing smoking. But there is the so-called RON nicotine. FDA in January 2025 have come to a conclusion that pouches are less harmful than smoking itself. And that was a really big event. I have also tried here to make this brief table that shows the risk spectrum compared to combustible cigarettes, depending on the form of delivery of nicotine. So speaking of toxic biomarkers in the bloodstream, people who use vapes, the level of toxin decreases by 50 to 95%, which is specific in the case of smoking. In the case of snus, despite an overall decrease, nitrate levels may be elevated. This is, and we know that nitrate compounds are added to cigarettes, but also sometimes they're added to snus. Now, pouches, they do not have such characteristic substances. As far as respiratory risks are concerned, vapes do not have any signs of increased risks of COPD, though acute cough is common. In the case of snus, there are no respiratory risks. In the case of pouches, sometimes there are cases of mucosal irritation in a small number of users. Now, cardiovascular risks. They're not increased, with the only exception that there may be a higher heart rate when nicotine is delivered to the bloodstream. As for cancer risks, most of the alternative products, that is, as far as vapes, snus, and pouches are concerned, they do not increase cancer risks. There are also non-pharmacological supports. This screening support strategy, the 5 ACE questionnaire that has been recommended. I understand that I need to speed up, so let me move on. There we can find what kind of recommendations should be. They should be clear and straightforward. They should be assertive and should be personalized. The consultant should be clear why you specifically need to stop smoking. Okay, you have an arthritis, therefore you need to quit smoking. It is also important to choose the specific date and to be very specific, because just the abstract wishes don't work. To conclude, smoking is a very complex phenomenon that consists of many different components. There are effective medicinal methods of support and non-medicinal methods of support. The use of non-medicinal products with alternative nicotine products fits the logic of medical intervention, so as maintain health and to improve health. Many thanks. Thank you very much. Now, just one question, because we have to move on. Okay, so please, your questions. Thank you for your presentation. I have one question. Is there any magic wand, a magic pill, so as not to gain on weight? Okay, I quit smoking, but how to prevent gaining on weight? Well, research shows that this is why people return back to smoking. Unfortunately, there are no magic pills. Nicotine itself reduces appetite. And those drugs that I have listed, bupropion, it has a very strong anorexigenic effect. It's also an antidepressant, and it also reduces appetite by 10%. So the body mass reduces by 10% after 6 months of taking bupropion. Recently, that is the GLP-1 receptor agonists that have appeared on the market, Ozempic and Mounjaro, are now on the market, and they are becoming more available due to generics in Eastern European countries and Central Asian countries. So the price is going down, but there are side effects. For instance, there is an elevated risk of pancreatitis. But actually, this is quite a promising group of drugs that helps us to control the body mass. Just a small question, if I may. What do you think the uh, uh, what do you think of topiramate? The topiramate reduces the number of people who actually ineffective with smoking. So topiramate, yes, may be helpful. There are some also alcohol dependent people. For them, there is naltrexone that is coupled with the fluoxetine. There is even a combined drug, and this helps to reduce the risk of recidive and to reduce craving for alcohol, but it also reduces the body mass. So it also helps to fight the gain in weight. Thank you very much. Thank you.